Well, in the U.S., the majority of patients receive EGFR antibodies after first line. To be clear, it's perfectly reasonable to give either bevacizumab or an EGFR antibody to patients in the frontline setting if they have a RAS wild-type tumor. But the practice in the U.S. has historically been to defer EGFR antibodies to later lines. Not that there's evidence that you should do it, it's just that it has been the practice. As such, all RAS testing is best done, I think, early in treatment so that when you arrive at the point where you need to make a decision, where there might be progression on frontline therapy, you have in your hands the data that tell you whether your patient can or should receive an epidermal growth factor receptor antibody. Of course, if you're contemplating an EGFR antibody in first line, you got to make sure that you can get RAS testing and all RAS testing quickly. I mention it because there are facilities that will do RAS testing, but it doesn't necessarily come back in just a few days. Sometimes it can take a couple of weeks. And if you're pressed to start therapy and you don't yet know the RAS testing result, you may start with bevacizumab and defer on EGFR antibodies for later lines of therapy if indeed that patient is RAS wild type.
And what are the data